paper I read this morning. How many of you like spicy food? Well, that was fast. All right. How many of you like hot food, like jalapenos and? All right. So what is the current reigning hottest pepper on the planet?
Is it a pepper?
Nope, not at all. Actually now it's a baby. The ghost pepper is going to be like cotton candy. So the ghost pepper is rated on a unit. How do they rate jalapenos?
Scoville.
What's a Scoville? Do you know?
Measured unit of heat or something.
Yeah, it's how much water it takes to dilute it until you taste like a green pepper. So you can actually not taste in it. So do you know what a average jalapeno is rated as? Just out of curiosity, put things in perspective. 5,000 Scoville unit. That's a jalapeno pepper you get in the grocery store. All right. A ghost pepper, which we used to think is the hottest thing, was 1.1 million Scovilles. Now there is the Carolina Reaper at 2.2, and that's going to be considered cotton candy for babies. I read a paper this morning about a new chemical that's found in a cactus, and that's like, you gotta be freaking kidding me. Oh my freaking God. This thing is rated not at 4 million Scovilles, not at 16 million. Oh, keep going, honey.
100 million?
Higher.
100 billion?
16 billion Scoville units.
In a
Like,
cactus?
It's in a cactus, yes.
What
All right. Well, so your first thought as a biologist, what the hell for? I mean, I understand 16 million Scovilles because capsaicin is just really a deterrent for you guys to not eat the plant. But here's where we get into physiology with this. Does anybody know any really kind of weird topical ointments that are put on burn patients to help minimize pain? Capsaicin lotion. The same stuff that makes jalapenos, oh my God, that's hot, right? Actually can anesthetize nerve endings by opening up your favorite topic. Calcium channels. Calcium comes in, you hyperpolarize the membrane, you can't send signals down that nerve anymore. So they can't send a pain message. So they use concentrated capsaicin on 3rd, 4th, and 5th degree burn patients to minimize the pain. Well, they've been using this stuff, apparently, for the last several years in either hip replacements for dogs. Now, here's the part of the problem. How do you know a dog's in pain? You can't ask it, are you in pain? And are any of you dog owners? Right? You got to realize dogs have an incredibly high pain threshold. We would be flat on our asses with the pain that they would experience. And they hide it really, really well. So when your dog shows pain, that thing is really in a lot of pain. They give these dogs injections of this stuff called RTX, which really is for resinifera toxin, is the name of it, resinifera toxin. And they give the dog an injection of this, and the owners will claim that their dogs run around like puppies for the next 12 months, showing no signs of discomfort whatsoever, and then begins to slowly wear off. So where's the human application of this? When you work with life-ending cancer patients, and they're in severe chronic day in, day out pain, there is no relief from the pain. Dilaudid morphine, they can be popping 30 pills a day and it won't even reduce the pain. They're looking at this stuff as a way of injecting it into your cerebral spinal fluid, let it go through the central nervous system, and anesthetize all of your pain neurons. It'll knock them out. You will not feel pain for the next maybe 5 or 6 months. And for a life-ending cancer patient, that's the first relief they've had in maybe several years, if not maybe decades. A friend of mine who's in with me right now is a cancer patient survivor. She's the only one in the world through nasopharyngeal. And she has constant tinnitus in her right ear. She's been hearing a high-pitched buzz for the last 28 years nonstop. She's totally deaf in her left ear and is losing hearing in her right ear, and she's been in constant pain for the past about 12, 15 years. She can take Dilaudid, like you guys take candy, but she's very careful with it. She only takes it when she's in really, really, really severe pain. But this stuff might actually help her. Knee replacement surgeries give you an injection of it. The only problem is when they use this stuff, they have to anesthetize you to give you the injection. I mean, if this is 16 billion Scoville units, imagine putting that in your mouth and the pain you would feel from it. So they knock you out first, give you an injection of this stuff, and in clinical trials, knee patients have complete mobility. They have no discomfort for about 5-6 months. So we're looking at this as a new pain replacement therapy because it's not an opioid. There's no addiction to it. There's no withdrawal symptoms. And it's a very easy way to do it. I thought it was just kind of interesting since we're getting into digestion. We're going to talk about gummy bears coming up next week and jalapenos. But I was really surprised at 16 billion Scovilles. So if there's a planet 16 billion, is there anybody at 30 billion? Who knows? We'll have to kind of keep our eyes out for that. All right, so here's why we're doing this. I can't have you guys be bored on Thursday, Friday, Saturday, Sunday, because what happens on Monday is a normal class day. And truthfully, how many of you here are going to be here a week from tonight? Most of you. Maybe mentally not all here because it's the day before what? Thanksgiving, right? It's a bit of a difficult night to teach. But I want to keep up with our habits of quizzes on Mondays to help you guys. All right? So, yeah, Anna. You will get a list of everything you need to know that I will consider fair game. We'll get a list tomorrow. Right? A part of it's going to be this stuff. And it's not hard, for God's sakes. You can learn it probably in a half hour on Thursday, half hour on Friday, half hour on Saturday, and you're done. You'll have learned all these little easy things that you can then help to raise your grade if you guys think you didn't do very well in the lecture or the previous lab. But I got to get you guys ready for your lab final, which is going to be here a lot faster than you're expecting. So, like we did for respiration, how we divided the system into a functional and non-functional aspect, we have the same thing with digestion. We have the accessory organs that aren't really the digestive structures. And then we have the literal digestive structure, like the mouth, the stomach, the esophagus, and digestive systems. And we're going to be looking through all this stuff in the next 2 lab lectures. So, to get with this stuff, a repeating theme. You guys had a pericardial sac. You had a pleural sac, heart and lungs. Now we have sacs around the digestive organs. We still have the viscera and the parietal portion, nothing different, but now we have a peritoneum. It's just another serous membrane that lines the inside of an abdominal cavity, and then the same tissue goes on top of an organ to create the visceral peritoneum. You ever heard of peritonitis? It's inflammation of this stuff. This is just, remember, simple squamous epithelia that makes this material. And from this, we are going to get this. That's why it's indented under the same category. 4 different types that are called mesenteric tissues. They're like a scaffolding or to help keep organs in place. Think about if you ever watched those really cheesy, gory movies where somebody gets sliced in the stomach and the guts come pouring out. Right? That would actually never happen. Because the mesenteries actually keep your internal organs inside. Even if you open up something like a little window and remove the entire front part of their abdomen, nothing's going to fall out because it's all still attached due to these mesenteries. And these blue dots are the mesenteries you need to know. There's only 4 of them. Upper top part here, so this is your stomach. And you see this little bit of a curve right here? And then you see this much bigger curve? Well, this bigger curve is called the greater curvature, which we'll learn a bit later tonight. But there is a serous membrane attached coming off of that greater curve. And that's called the greater omentum. And that actually dangles all the way down the front part of your abdomen. It's known as the abdominal apron. When you actually do an autopsy on a human being and open them up, there's this literal sheet of serous membrane full of fat. You have to literally roll it out and get it out of the way so you can see the intestines. When I bring kitty cats out for you guys, literally, kitty cats, next week, you're going to see their abdominal fat sheet. And you're going to go, wow, that thing is huge. I mean, it's going to be about this long and about that wide inside of a little kitty cat. And you can literally just, like an apron, pick it up and just kind of push it off to the side. So you can see the intestinal tract and the stomach and stuff underneath. And they cut it away so you can actually see what would be found below it. This other little curve is called the lesser omentum because it's on the lesser curve. And this attaches to the back part of your abdominal wall. This helps to keep your stomach in place. This helps to keep the stomach in place, but also serve as a place for lots of adipose tissue. Then we have over here what's called the mesentery proper. If you look at the diagram, it's the stuff that connects to your small intestine. So any mesentery that hooks up to the small intestine is known as mesentery proper. But any mesentery tissue hooked up to the large intestine, we're going to simplify it, and for you guys, just call it mesocolon. That's it. Not what part of the mesocolon, just mesocolon in general. There's actually 4 different regions of it. We're just going to keep it simple. Any mesenteries around the large intestine is all mesocolon. Any mesenteries hooked up to the small intestine is mesentery proper. Any mesentery tissue hooking up to this lesser curve is going to be called the lesser omentum. And any mesentery tissue dangling off of this greater portion is going to be called the greater omentum. If I turn you sideways, you look like this. Now we're looking at the side. You can see the stomach, so there's your lesser omentum. And if you look right here, there's the curvature of that apron that dangles over the front part of your intestines. That's the greater curvature, the greater omentum. But now we can see the idea of the mesentery proper, right, hooked up to all of your small intestines. And then we have this idea of the greater omentum, the transverse colon. That's just for you to see the word mesocolon for the large intestine. Just the word mesocolon. Don't worry about transverse part. But I also want to point out that we can look at your parietal peritoneum, this layer that covers the inside of your abdominal cavity. If you look at it, there's an organ found right behind it. Just like the kidneys were retroperitoneal, we have some digestive organs that are behind the parietal peritoneum. Everyone with the red star is retroperitoneal. Right? The pancreas is tucked behind it, up against the abdominal wall. The portion of your duodenum, which is called your small intestine, is actually retroperitoneal. Part of your rectum is retroperitoneal. Part of the bladder is retroperitoneal. We have actually a lot of organs that are literally behind the parietal peritoneum. All along through here. So that's behind it, right? This is behind it, because there's the parietal layer right there. Right? Even a part of the uterus, which we'll talk about at the end of the quarter, would be considered retroperitoneal. Right now we're just doing digestive stuff. Here's a cartoon to illustrate the lesser and greater omentum. So you can see the apron-like appearance. They cut half of it away so you can see what would be behind it. That's just an image to let you see what it would look like. And then an actual photograph of a kitty cat, which you guys will see next week. But you can actually see the small intestine, and there's the tissue that keeps the small intestine in place. That's why the tissues don't fall out if you open up an animal, whether human or otherwise. Right? There's your greater apron that's all lifted up. Kitty's head would be way up here. But you can see there's a lot of adipose tissue in here. Now, one of the benefits of this, having these mesenteries, has anybody had a chance to ever watch a vet do surgery on a cat or a dog? It's kind of interesting. If they have to do any kind of abdominal surgery, they might make an incision just about this long. And they're going to reach in and pull out what they're looking for, especially like, dogs swallow socks and they get stuck in their intestinal tract. They'll make an incision and start to pull out the intestines until they actually come across the part that has the sock in it. But since it's all connected, right, to the back part of the wall, it's simply like pulling out an extension cord. They pull it out and they just keep looking for it. They find it, they open it up, they remove the sock, save it for the customer. They sew it back up, and then they simply just take their fingers and stuff it back in, because it's all connected by this tissue. So it can never get twisted on itself. It can never get flip-flopped. That's why they can simply just tuck it back in and sew the kitty or the dog back up again. And the same thing for you guys. When they run your intestines, they simply just have to poke everything back in, because it all falls back into place because of these mesenteries, right? That help to keep everything in. There's no way for this to get tucked underneath that. There's no way for this part to get flipped over and end up with the first part, because it's all hooked up. It's all anchored. So the order never changes. And it's because of the structure of those mesenteries. All right, now we have to start a very universal, broad topic. We're going to discuss the 4 major layers of any part of your digestive tract. That's going to be from the mouth to the anus. And in that mouth to anus pathway, we have 4 major layers. And once we get past the 4 major ones, we're going to go back and look at each part individually. The mouth, the esophagus, the stomach, the duodenum, the jejunum, the ileum, the ascending colon, the rectum, and such, and see how these 4 layers change in different locations. This is just the foundation template in a sense. And our 4 major layers, from top to deepest, are the mucosa, submucosa, because sub means below, right? You have the muscularis externa, and then the serosa, sometimes known as the adventitia, that we'll see in the next coming slide. So this is the layer up against the food, right? This is the inside of your mouth, it's the inside of your esophagus, the inside of your stomach, the inside of your intestines. When you swallow something, that stuff is touching this. Everything else is underneath it. A little more specific, it looks sort of like this. And we'll learn more of this when we get to your intestines, but there's my mucosa, so that's the topmost layer. And you see the little finger-like projections, that's what this is. It's one of those magnified. So, from the topmost layer, right, we have epithelium. The epithelium covers the outside of a structure, right, or lines the inside of it. And just to drum that in, right, if you take your finger and touch the inside of your mouth, that's epithelium. That's mucosa. If you could take your fingers and go down and touch the inside of your esophagus, like a gag, right, you're touching the mucosa of your esophagus. And then right underneath it is a layer of connective tissue known as lamina propria. So that's the topmost layer. The layer right below it is the lamina propria, still a part of the mucosa. And there's one third part that they really should have stuck right here just to make it sensible. But come all the way down here to where it says muscularis mucosae. It's these 2 layers right here. It comes up right along through there and comes down through there. It's easy to see right there. There's 2 layers, a top layer, right, and a layer right underneath it. This is the very bottom of my mucosa. And these 2 layers are a layer of smooth muscle tissue. The topmost layer is known as the circular layer. And the one right below it is called the longitudinal. And then longitudinal. So to practice that, stick your arm out and make it like your esophagus or your intestines. Circular muscles go around like a wristband would for a watch. Right? That's the circular pattern. Fibers that run along the length of your arm are longitudinal fibers. So we have a layer that's wrapping around my intestinal wall, but these guys are running lengthwise. And that forms the bottommost layer of my mucosa. The next layer in purple is the submucosa, because it's below the mucosa. It's just connective tissue with some glands we'll talk about in a moment and some arterioles. But in the very bottom part of your submucosa is a submucosal plexus. The only trick is, do you remember what a plexus is from 241? Plexus means braid. Remember, it's a braid of nerves. It's where nerves merge together to form a bigger structure, like you're joining cables together. Think about the old-fashioned rope. You can see the braids of the rope? That would be a plexus. You actually undo one strand, and then that strand is made up of yet smaller strands. Well, that's what this is. It's a collection of nerve endings. Then we have the muscularis externa. And the same pattern. Topmost layer is circular. The layer under it is longitudinal. So same thing. Circular, longitudinal. That's a layer of smooth muscle, but it's in my mucosa. And it's really very, very thin. This is much thicker. Big, obvious circular because the fibers are running out this way. And these fibers are running this way. So you can see the longitudinal part and you can see the circular part. But sandwiched between the two is another set of plexes, known as the myenteric plexes. That yellow plexes makes these 2 muscles contract. They're what are going to stimulate the circular and the longitudinal layers, which we'll talk about later next week in terms of physiology. And then I have my outermost layer, known as the serosa. And again, it's connective tissue that holds blood vessels in place. And that's a little more of a detail of the template of the 4 major layers. And we're going to see these names again, but now we're going to be more specific, region by region of your digestive system. So you kind of drum it in terms of what's found in these and what's a little bit different in each. So, to remind you what's in the mucosa, remember it's lined by epithelium. The only problem is going to be what kind. It's going to vary. It's going to vary from, whoops, come back here, from stratified squamose, that's keratinized. Stratified squamose that's keratinized, all the way down to simple columnar. And we will point out how it is that way in each different part. That's just the big cookie cutter idea. You will find mucosal glands in this mucosa, that's why they're called mucosal. They basically just make mucus. And that's how lubricate food as you swallow it. So it goes down rather easily. Remember, we are still in the mucosa layer. There's epithelial layer. Under that, you're going to have mucosal glands. And in my mucosa layer, you're going to have this nice little word in blue, which a part of it you should recognize. See the word endocrine? All right, these are endocrine cells. But the prefix, meaning entero, refers to digestive system. These are going to be digestive system endocrine glands that are located in the mucosal layer of your digestive tract. And we'll learn all about them next week. If we have any folding of the mucosal epithelium, then we call that folding plica. It's like pleats. Like, think about closing curtains, not opening but closing the curtains. And the pleats in the curtains, right, we would call them plicae. And we'll point those out as we see them. Then we still have the mucosa, right? The lamina propria is where you'll have blood vessels that feed the epithelium. You might even have additional mucus glands, especially if you're in the oral cavity or the pharynx and esophagus, or the first part of your small intestine, and we'll name those off as we come across them. But then there's that little thin layer called the muscularis mucosa, right? Which, remember, is this layer right here. It's the very bottom of your mucosa. Remember, it has two layers, the upper circular, and right under it is the longitudinal, and they are made of smooth muscle tissue. Remember, smooth muscles you cannot control. It's a voluntary type of muscle tissue. Your brain takes care of all the work for you. You cannot control them voluntarily. Okay?
Sorry, I thought you said that the top layer is circular.
Yeah, it is. Top layer is circular, right?
Oh, and that is
Top
the
layer
most
circular,
innermost.
that's the layer right underneath it.
Gotcha.
Okay. Okay. Off to the submucosa. It's going to contain blood vessels in terms of arteries, not arterioles, but arteries. And then we're going to have some lymphatic tissue we're going to talk about next week. But remember that yellow stuff I showed you guys? We need to go back one image. We call it the submucosal plexus because it's a plexus of nerves found in the submucosal layer, which makes complete total sense. But you guys love multiple names. A lot of books use this name instead, the plexus of Meissner. I don't care which one you use. But a lot of books do throw that term out at you. Rather than calling it a submucosal plexus, they call it the plexus of Meissner. It is a collection of parasympathetic and sympathetic nerve endings. Remember, that's your autonomic nervous system, which means you do not control it. It is automatic. And we'll see how they work next week. You might have some exocrine glands like buffers that create bicarbonates or digestive enzymes that we'll talk about next week, but your enzyme producing glands are found in the submucosal layer. Not in the mucosa, not in the muscularis, but in the submucosal layer. Now let's get to that really big, thick outer layer one more time, the muscularis externa, right? It's external, that's why it's called externa. It's on the outside layers. Its function is to move material through your digestive tract. And the word we use is bolus. So rather than saying the piece of hamburger you swallowed, I'm going to call it a bolus of food. And that bolus is going to move along, and it looks more like a cat fur ball in terms of its shape, and that's how you can think of it. It's a little mass of food. Well, to get it down your esophagus, into your stomach, through your intestines, these muscles have to contract. And to reinforce their layers, right, I named the circular one as the top, because we're going from the top mucosa, we're working our way down through the layers. You can see in between the circular and longitudinal is that myenteric plexus. It's this stuff right in here that I put a red star next to, since we're on the slide right next door. It's another collection of sympathetic and parasympathetic fibers. Again, meaning you guys don't control it. But it is this circular layer and the longitudinal layer. It's these two that make the food move through your digestive tract. Hang in there, Anna. Now, here's how we can look at it. This is how that layer of muscles work. So there's your bolus of food. This is maybe your esophagus, or it could be your small intestines, doesn't matter. The way it works is, if I contract the circular muscles behind the food, and I relax the circular ones ahead of it, like going toward my intestines, then I can squeeze this end, relax that end, and then I contract my longitudinals like I'm squeezing a tube of toothpaste, and it moves the bolus a little bit further. Then I squeeze the next part of the circular behind it, I relax the ones ahead of it, and I then squeeze my longitudinals, and it moves to the next part. We can simply just relax or constrict circulars, relax those, constrict the longitudinals, and it moves along your digestive system. This is called peristalsis. Right? It's moving stuff from point A to point B to point C, down, down, down the length of your tube. Now the other difference is over here, the other side, called segmentation. Look at the very top image of the bolus, then look at the very bottom one. See how it looks like we took that big piece and made it into little segments? Right? That's why it's called segmentation. The way it works is your intestines are going to constrict and constrict. They're going to shove the bolus this way, then they shove it back this way. It's like swishing mouthwash in your mouth. We're just going back and forth, back and forth, back and forth, until we work the big chunk into smaller little teeny pieces. And that we're increasing the surface area, which we'll talk about next week, as you make it easier for the enzymes to digest and break down the chunk, because there's more surface area to work with. So the way it actually works is, in your intestines, we're going to do some segmentation to make a big piece into a smaller piece. Then when we stop it, we do some peristalsis to move it along. And then it does more segmentation than peristalsis, segmentation, peristalsis, and it literally sort of like driving a clutch and popping the clutch as you move down the street. It hiccups and moves, and it moves, and hiccups and moves. And that way we allow it to break it down into little teeny tiny pieces.
So, do you start with peristalsis or do you start with segmentation?
You have to start with peristalsis, because you got to actually get it to
the big piece of food
right
first, push it, and then you break it down.
Yep. And we're going to reinforce that in a moment when we get to the esophagus. But if moving down your esophagus, through your stomach, through the intestines, and out the anus is peristalsis, what do you call it if you go the other direction? What words do you guys have for it? When you drink too much and you got to talk to the porcelain god? Right? We call it barfing, vomiting, upchucking, puking. We call it reverse peristalsis, because you're going just in the reverse direction, because it works the exact same way. Just more forceful contractions. And minus the segmentation part. Alright? And since Anna just went, ew, I need to point this out, because we're going to talk about this next week. Hopefully you won't experience this in the next 3 weeks. But if you're with someone, or think about your memory of you having had to throw up in the past, and you notice different textures of the vomitus. Sometimes it's really liquidy, and other times you can tell what you just had for lunch, because it only came out about 4 hours ago. And you can see the chunks of stuff. Well, that determines how far down your digestive tract it's gotten to. If you get food poisoning, then you're going to get to see what you had for lunch. It'll come up within a matter of hours. Very little segmentation's ever happened. But if the poison is severe enough, but it's slow acting, like E. coli, and you end up throwing up and it's really, really liquidy, that means it actually got past the stomach and it's halfway through your small intestines, or almost halfway. And your body goes, okay, where's the closest door? Is it John's mouth or John's anus? Whichever's closest is the route you take. And if you're kind of right in the middle, you guys ever had that unpleasant experience where both ends are working pretty quickly? Right? You get both vomiting and diarrhea because both are the fastest ways out of here. But that's why you guys have vomit and diarrhea. It's to get crap out, pardon the pun, it's to get stuff out of you as fast as possible because there's toxins in it. And throwing up is the best way, but a lot of times it's even past the digestive point. It's all called reverse peristalsis. All right.
Do you call it all the longitudinal mucosa? Mucosa? How do you say it?
Longitudinal mucosa?
Mucosa? Is it always the longitudinal? How do you say it?
Well, remember, these are muscle layers.
Okay.
It's not a mucosa. Remember, the mucosa is the topmost layer up against epithelium. This is the muscularis externa, right? That's this layer right here.
Oh.
Right?
Okay.
And it's also those two layers right there, right? It's the muscularis mucosa of the mucosa layer. And there's a circular and a longitudinal part of the muscularis mucosa of the mucosa layer.
But in the peristalsis,
Peristalsis, that's going to be the muscularis externa working to do that job.
Okay, thank
And you're going to have the circular muscles and the longitudinal muscles.
Thank you.
All right, so let's get now, that's the end of the template cookie cutter, every part seems to be the same. Now we start going through specific parts of the digestive tract and see how it varies, how it's different. We're not going to get through all these tonight, don't worry. We're only about another half an hour, maybe 40 minutes. All right, so with the oral cavity, the buccal cavity, you have what's called the hard palate and the soft palate. If you take your tongue, all right, or your clean fingers, put them on the roof of your mouth and feel the top of your mouth, feel the washboard-like texture, and that's due to the hard palate that literally has ridges in it in the mucosa that's lined with stratified, keratinized squamose. You want really hard, tough skin in the top part of your mouth. Think about what your classmates pointed out this morning, Captain Crunch cereal. Imagine chewing that stuff, right? Or walnuts or almonds, right? Hard nuts, hard food, apples and chunks, right? That's going to tear the top of your mouth off unless it's keratinized, stratified squamose. It's like leather tanned skin almost. And that's on the hard palate. If you take your fingers and go to the back of your mouth, right? So here's your mouth. That's all your hard palate. The palatine bone is the dead end of your hard palate.